Welcome to Eye Contact, a video news programme on issues and controversies in ophthalmology, sponsored by EUROTIMES. I'm Richard Packard. With new intraocular lenses come new challenges in diagnosis and management, and deciding which lens is best for which patient. We're here today with Dr Pablo Artal of the University of Murcia in Spain to discuss how the use of adaptive optics in visual assessment may lead to better visual outcomes for our patients. Pablo, you are using some really very sophisticated equipment now that you say allows you to predict how patients will do with various IOL options. Maybe you could tell us a little bit more about the instruments that you're using at the moment.
Sure, I'm very happy to do that. And the instruments that we are actually using for many years are based in a technology that is called adaptive optics. This technology has been used in other areas of science, particularly in telescope, in astronomy, for a number of years. And basically the idea is that you can correct for the optical error, for the optical aberrations in any situation. In the case of the eye, we have a very similar problem. So about 20 years ago, we and others were basically trying to use this technology, initially actually link it with ophthalmoscope. We were actually interested in getting better images of the retina through the optics that in many cases is not perfect. Like a new concept, we're thinking, well, you can not only use adaptive optics for correcting the aberration, you can also use adaptive optics for manipulating the aberration. So you can basically induce any particular optics in your patient's eye and do visual testing. And this came with the idea of adaptive optics visual simulators. And this has been in the laboratory for many years. This consisting basically in a aberrometer and a corrector device that basically it's the formol mirror or a liquid crystal device. In any case, this is technology. And you can put all this in a box, in a standard type of ophthalmic instrument, allowing to control basically any optics that you want to induce into your patient. And this is basically ready. It's ready to be used in the clinic. And as you mentioned, I believe with a lot of possibilities in different clinical applications.
So how does that do better than what we have at the moment by way of conventional methods of doing this? I mean, what does it give us? I mean, with the so-called premium lenses, obviously it becomes more important because they have different optical effects. So what will this give you or give the surgeon when he's choosing these different lenses for his patients?
Well, the beauty of this type of technology that I believe, I really believe that is going to be very common in ophthalmology in the future. Sometimes I try to make the analogy that what was aberrometry like 15 years ago, that seems to be like a little bit strange at the time, and now is so common for everybody. Adaptive optics will be something similar and even more, because I believe there is a lot of real practical application. But concerning your question, basically you have many possibilities, but one possibility is that before any intervention, that can be IOLs, but can be also any type of refractive procedure, you basically can induce into your patient a different option, different solution. You can get the feedback for your patient. And of course, you can also do visual testing. You can measure visual acuity, contrast sensitivity, any type of color testing, and you can eventually do also stereo problem when you are doing binocularity. So you can do a lot of testing in advance with basically the same optics that you are intended to do in the future. What is the potential benefit? I think it's enormous, because you can distinguish what is going to be best or what is going to be not appropriate for your patient. Avoiding, of course, maximizing visual outcomes, but especially you can select patient. That I think now is a kind of a critical issue, not very well solved.
Given the fact that with multifocal lenses, there's the issue of neural adaptation, how does that play into this? Because one of the problems is if you're going to get a device like this, which I think is great, you show it to the patient, you sort of get an idea about how it might work for them, but you know perfectly well that patients that having these lenses can actually overcome quite a lot of the aberrations that are there because the brain takes over.
Well, this is a perfect question. I should say. So you are absolutely right. And this is something that you need to consider. However, neural adaptation, and we have a lot of studies and all people, is if you can expect something from neural adaptation, and it's something that is expected and more or less limit. If there is a real bad optical situation, something that is really bad, patient is going to be unhappy and neural adaptation is not going to help. So I think you can distinguish between these two situations, and with future studies, you can really get like a threshold. Say, well, maybe the patient is not completely happy with this particular solution, but you know that based on these responses, based on this measurement pre-op, neural adaptation is going to help, or not. So I think you are completely right, but you can use in a kind of clever way to really take in consideration the future neural adaptation. That you are right. We are not taking in consideration when we are measuring.
Given the stage that you're at the moment, when do you think that surgeons like me will have the ability to use this technology on our patients so we can make these choices and help them make their choices?
Well, I think it's basically ready. So there is commercial units that some hospital research units and clinics are using. So it's basically ready, and what is needed is to be more people using, and especially more industry linking solution, because of course you need to know exactly a particular IOL to be incorporated in the system, so it needs some type of development, but it's already available. Mm-hmm. So it's there. The future is here.
Excellent. Now, let's move away from solutions using lenses. What about the cornea and LASIK? I mean, there are surgeons out there who are doing presby-LASIK. Do you think that using this will help them choose patients who are likely to be able to do well with this sort of procedure?
I'm also convinced. Actually, we did a study with Professor Malekas a couple of years ago. It was published in the Journal of Ophthalmology. And I think the potential for presby-LASIK is enormous because, again, some presby-LASIK patients are extremely happy, other patients are not very happy, and I think the key issue is customization of the parameters. So you can customize, and then you get a correct answer. The difference, the conceptual difference from IOLs and refractive procedure on the cornea is that we don't have a complete control of what is going to be changing in the cornea after the ablation. So again, we need some extra time. We need to get links with the laser manufacturers to really control this process. So it's still a little bit of less certainty in this, but will be. So when we link these two things, when we know more carefully what the ablation are doing, we will be able to customize and personalize these treatments, because I'm convinced that the difference between success or not so success is very small fine-tuning of the parameters that you can really do with this approach. Either deciding if you want to go ahead with the treatment, and once you decide you want, then basically you can customize diameter of the treatment, the potential spherical aberration you are inducing, etc., etc. So I think it's going to be a lot of promise also in not only presby-LASIK, basically any type of guided corneal treatment.
So from what you're saying then, in both lens and corneal surgery, this for refractive purposes, this is going to be big in the future for most people in their clinical practice.
I'm absolutely convinced. I don't know. So this is like, I cannot think something different, because you know that typically in medicine, in ophthalmology, there is people is conservative. It's taking some time to get, but in this is so clear, so obvious, so potential benefit that I believe everybody is going to, once people try it, they cannot imagine how they can be using without this before. So I'm completely convinced. So it's just a matter of time.
Excellent, Pablo. Thank you very much. Thank you for joining us. And if anybody wants more information about this or other related topics, please visit us at eurotimes.org. Thank you.